like for the last couple of weeks, that will be on the Unit 3 exam. So patient care models, disaster prep, IET, quality improvement, and then just some review to kind of start thinking about things for the upcoming final exam. That will be on, you guys said Monday of week 15, right? Is that what you guys want? Just make sure we're on the same page there, scheduling wise. So we can go through this and talk through it, see if you guys have any questions about other things as well for our review today. So where would you guys like to start?
Patient care models for 100.
Patient care models for 100. So what is total patient care?
When the nurse assumes responsibility for everything, including like all the tech type of stuff.
Yep, that's exactly, yeah. So total patient care, the nurse is responsible for total care of the patient during the nurse's working shift. So what, like when are times when total patient care is used?
And there aren't enough techs.
There's not enough techs, yep. Have you guys done total patient care model?
I've been the tech, that could have used some more techs.
Yeah. When have you guys done like total patient care model?
Wouldn't it in the ICU, isn't it usually, like
Yeah.
typically I feel like in the ICU it's usually total patient care.
Yeah, ICU can be total patient care. They don't always have techs on. So ICU is a common place where we can see it. They have techs, it might just be one. A lot of times in the ICU, you're either like 1-to-1 or like 2 to 3 to 1, so you typically don't have as many patients.
I feel like when we first started the program and we were like not as advanced in our clinicals and we only had the one patient, you were with them the entire time.
Yeah, so kind of like 310, you're responsible for total patient care, so pulling what you learned from 250 and adding it onto 310 as you're kind of working on developing like that time management, critical thinking as you're caring for your patients. And then 320, kind of probably at the beginning of the semester, doing total patient care, but then as you had more patients added on, working on delegation from there, and working with your PCTs more so in delegation. Very good. What next? Just want to go down the line?
Yeah.
Want to go this way or this way?
Down.
Down, okay. What's functional nursing? What's that care model?
Oh, that's the one with each person has their own role, so like one nurse gives all the meds, one nurse does all of the whatever.
Yeah, so the kind of more of the task oriented. So, like, yeah, one nurse is in charge of all the assessments, one is in charge of all the medication administration, or you might have like an LPN that's in charge of all like PO, med administration, things like that. Someone, you have the tech one tech that's maybe in charge of like vitals, and another that's in charge of like bads. So what are some like pros and cons to this?
It's like easy to like have more like a med error because you can't keep track of 30 people or whatever.
Yeah, so you're having to keep track of a lot of people. Maybe the nurse that's doing the assessment reports something to you, but then by the time you get to that patient, you've like forgotten or forgot like who it was, and even if you wrote it down, maybe you can't find what it was. So maybe errors would be more likely. If it's task oriented, is that necessarily utilizing critical thinking and like looking at, no, it's not really utilizing critical thinking as much.
It could be confusing for the patient.
Yes.
Because if they ask you something, but it's like, oh no, the nurse that did your assessment's gonna answer that or something.
Yeah, understanding like what each nurse's role is would be difficult for them. Definitely. What is team nursing now? Which one's team nursing?
Like, there's LPNs that help out with, it's like a team. You have techs and LPNs and nurses all working together.
So you have like a team, a group that's assigned to a group of patients. You have the RN, it's a team leader, and then you might have like another RN and an LPN, or 2 RNs and LPN, you know, like a mix of RNs, LPNs, and PCTs. And then that group is gonna be taking care of, you know, say 10 patients. And so they're gonna be working as a team, so needing to collaborate and communicate effectively with each other. And so they'll work to kind of figure out who's gonna do what for the patients that day. So team nursing is something that a lot of hospitals are doing more right now to address the shortage of nurses, and especially as we have more LPNs hired onto the floor and in the hospitals. What questions do you guys have about team nursing? What is modular nursing?
Is this the one with you're like assigned the patients in rooms right next to each other?
Yeah, that's it exactly. So it's gonna be more like you're assigned based on like the demographic location on the unit. So like maybe you're assigned to rooms 1 through 5, and those are the patients you're gonna be caring for. And then the next nurse is like 6 through 10, and that's who they're caring for. So you're gonna be close to all of your patients, so you're not necessarily having to run from one end to the other. And so that can help with care and make it so you're not running around as much. But then also your acuity might be different from nurse to nurse. That's like the acuity of their patients that they're caring for. What questions about modular nursing?
So like with questions like this on the exam, is it gonna be, I don't know, like are you gonna give a situation type thing, not more like a definition, but?
Yeah, cause yeah, it's gonna be more of a situation, so we think about like with nursing exams, do the application portion of it, so not gonna be like the definition of recalling. Yep. So when are times when modular nursing might be used?
I saw it in the ED.
ED, like a lot of times ED nurses will be assigned to like a chunk of rooms, and so then if a patient goes into that room, they're gonna be taking care of it. Can sometimes be like ICU as well. Last one, primary nursing. What is primary nursing?
Is that like,
Yeah, you go.
is it like total care kind of?
Somewhat like total care.
Like when, what was I gonna say? Like the fostering the strong relationships, so then they're more likely to tell you things.
Yeah, so you have your primary group of patients that you work with for as long as the patient is on the unit, so kind of to help with that continuity of care. So we kind of do like modified primary. You're not always gonna be assigned to the same patient every time that you're working, but they try to somewhat do that or have it be like the same nurses for that continuity of care. So you like, you know, like you'll be a client's primary nurse, and then you'll collaborate with the healthcare team, you know, delegate to the PCT. So then they'll have you, like sometimes we just need breaks from patients, and so they'll, you know, maybe assign you to someone else for a little bit, but to try to help with that continuity of care. Yeah, Joanna?
So would that be like every time you go to work, like you would have the same patient until they leave the unit, regardless of how long they're there?
Yeah, yeah. So that's why I said we kind of use more of a modified primary, because you're, like a lot of times you'll be assigned to the same patient, but if it's someone that's there for an extended period of time, they might change it up. Just sometimes just to prevent, you know, burnout for us if we get tired, like depending on how that patient is, we might need a break and then go back to them. What other questions do you have about primary nursing? Disaster prep here. So while triaging the wounded from a disaster, you know that one of the wounded is not breathing, a radial pulse is absent, cap refill is greater than 2 seconds and does not respond to your commands, what color of tag is assigned? Black? Yep, so black.
Your simulation was like very lifelike. It was kind of scary.
Wasn't that? Yeah.
Like I was like, is this live?
Oh, like the one where you could click around like the videos, like that had the videos and showed, yeah,
I
'cause
was like-
the plane crash one, but
Yeah.
Yeah, to see like how it all works and everything. I thought that was a good one. Cause then it like gives you an idea of how things look, because like it's just hard to kind of comprehend like how things would be set up at that site.
Right.
The wounded victim is unable to walk, has a respiratory rate of 19, cap refill of 1 second, and is able to obey your commands. What color?
I don't know.
Yellow? So you can say yellow, so yep. Just remember, like cap refill was less than 1 second, so a good cap refill, respiratory rate was lower. They were following commands, talking to you, so they didn't need anything like, you know, like immediately. They would be fine waiting for a couple hours. Wounded victim is unable to walk, has a respiratory rate of 12, cap refill is 8 seconds, and is unresponsive. What would you do for this one? Red. Yeah, red, does everyone understand how we got to red with that one? Good look, it's, we have a long cap refill, so I think if the cap refill is greater than 3 seconds, automatically it becomes a red, because we're looking at circulation there. If they're unresponsive, again, that automatically makes it a red as well. So, wounded victim is able to walk and obey commands, what would we do? Green, walking wounded, so they're up walking, talking, like if they aren't seen immediately or even in the next few hours, they're gonna be fine. Last one here. So we have a catastrophic disaster has occurred 5 miles from the hospital you are working in. The hospital's disaster plan is activated and the wounded are brought to the hospital. You're helping triage the survivors. One of the wounded is able to walk around and has a minor lacerations on the arms, hands, chest, and legs. What would you place color of tag on the survivor? What color? Green. And why green? Yep, walking wounded. So as the nurse, like say you're at the hospital and you get the call that you're getting victims, what is your role? What can you do? What are different things? I mean, it's gonna be dependent on where you're working, like what unit, but what are different things that nurses can do in the hospital to help with disaster preparedness, disaster relief?
Repair the rooms, supplies.
Yeah, prepare the rooms, make sure the rooms are stocked with the supplies that will be needed.
You can see what patients you have on the unit that could leave.
Yeah, see who, like, maybe we can transfer to a different unit, who can be discharged, we can open up, some space, some beds. Are you guys familiar with your, policies in the hospital as far as if there's a tornado warning, or a tornado, what you're supposed to do? Is it there? Okay. So that's something when you start working to think about, or, you know, depending on where you are, like what, for like disaster things to be prepared for, so looking at your policy for that. So a lot of times it's, you know, hospitals have generators, so think like those that are on like vents and things like that, if power does go down. It can be on, you know, the red outlet, like you wanna make sure stuff's plugged into there, because that's the one that's on the, generator. Moving people into the hallways if you're able to. So just, yeah, I recommend looking at your hospital policy, because it might vary a little bit, but I know like people that can't be moved into the hospital or moved to a safe area, you know, we close the blinds, we cover them with pillows, things like that, so that if glass were to break, it doesn't hurt them. So when you're working, you'll have like tornado drills and things like that, so you know how to respond in those, situations. And if you work in emergency, you'll have, like disaster scenarios that you go through, like we would have to do disaster drills, and they wouldn't always warn us about it, so it made it even more realistic and fun. So then as we're taking care of our other patients, we're having to do the disaster drill type thing too. What other questions do you guys have about disaster prep?
I don't have a question, but I have a comment. I
Yeah.
saw a TikTok earlier this week, and it was a nurse who was avoiding Gaza, and he was talking about, how, us nurses take advantage of, just having power, because he was talking about how he had to think through what he would do if they were to get bombed and lost power. And he walked through, like, I would have to bag my patient, I would have to basically just let the, like, if they're receiving blood or if they're on ECMO or something, we have to let the lines clot because there's just really nothing else you can do. And he basically was like, yeah, we would just stand there and bag them until they die. And I was like, wow.
Yeah, cause hospitals are being bombed over there.
Yeah, you don't really think of, I hope that never happens.
Yeah,
But you never think of those situations.
yeah, don't think about how fortunate we are
Yeah.
here. Yeah.
We constantly have all of those resources at our fingertips.
Yeah, cause I mean, yeah, sometimes we're short on things, like I remember there's like the saline shortage and things like that, but it's like,
That's minimal.
yeah, right, in the realm of things. Like I've done some mission trips down in Nicaragua, and like one of the hospitals that we were at, like they were running out of oxygen, and I'm like, and here we're like, it's just in the wall, right? You just plug it into the wall, but no, they have like the actual like big cylinder canisters, like as tall as us, and we're just running out of oxygen because they are not built to have all the supplies and everything like what we have, and this was like a newer hospital. It's just very different, and just how different countries' healthcare systems are set up, and we don't have to thankfully worry about, it's not on the forefront of our mind that our hospital that we're working at is gonna be bombed or attacked type of thing. I mean, the things that we have to consider more so, for like the disaster preparedness and mass casualty events seem to be more gun violence. Cause it can happen, in schools, they have happened in hospitals before, just even in Omaha, at Creighton a few years back, there was a shooting there. So that's what we seem to have to worry about more, and then just natural disasters. Yeah, I can imagine like having to think about just manually bagging patient until they died, so kind of just essentially providing comfort cares while you can to who you can, and
And you can't call for help because your coworkers are doing the same thing. Like,
Yeah.
go on.
Yeah.
I can't, that just boggles my mind. Sorry if it's
No,
kind
you're
of
fine.
off, but.
Well, no, because it is, goes along with kind of that disaster preparedness and things to think about, and just how fortunate we are. The things that, like the things that we have to deal with are occasional like shortages of certain supplies and medications, and the whole scheme of things, like, it affects us and it's difficult, but then, you think about what's going on in other countries and other places, and it's hard. Everything that's going on, like, we're there in Ukraine and Russia and everything, it's just hard. Like, just their access to everything. And then, the people that are, injured in the bombs, they don't have the resources, and maybe can't even get to the hospital, and then if there is the hospital there, do they have the resources type of thing? So we'll go into IT for 100. So what is the purpose of the safer guides? What are our safer guides?
I'm gonna guess it's a set of self-assessment tools aimed at helping healthcare organizations evaluate their EHR safety practices, identify potential risks, and mitigate those risks. Just
There
off
you
the top of
go,
my head.
just off the top of your head.
Yeah.
Pull that out real quick, right? So it's gonna be, like Kimberly said, off the top of her head, tools that include checklists and recommended practices designed to help healthcare providers and organizations, so help support them to assess, optimize the safety and safe use of electronic health records. So when we have EHRs, pretty much most everything, is EHR based. Some places might still use like paper charting, depending on what it is. So what are some things that you do to, promote like the safe use of EHRs as nurses?
And like log out when you walk away.
Yeah, always logging out when you walk away. So yeah, either, so depending on where you work, you'll have different types of ways that you can log in, it might just be username or password. I know Unity Point, they have the badge. Broadlungs, has a badge. We've also had like fingerprint is what we would use to scan into, so we'd scan our fingerprint and just put our fingerprint down.
And individualized codes and passwords on top of the scans.
Yep. You have individualized passwords, making sure that you're not sharing your password with anyone else. Making sure that if you sit down to document and someone's logged in, you log out and log in under yourself type of thing. So again, just, it's to have safe electronic health records, and then also it's just, to protect your license too, because, like, you don't wanna cause like a HIPAA violation. You don't want someone to document something under your name that you have nothing to do with, and then, it goes to court, and you really have no idea what's going on, because you actually did not care for that patient. Oops. Well, here, I'm just gonna, what is the HIPAA privacy rule?
Not sharing patient information unless we have permission.
Not sharing patient information unless we have permission. So, yeah, that's when we're kind of looking at, so the privacy rule is looking at our unique client identifiers. So, examples here would be social security number, date of birth. What else can we use as those client identifiers? Their MedRec number. Yep, so name, full name, date of birth, MedRec number. What shouldn't we use as patient identifiers? Telephone number, room number, things like that. So it's ways that we can link them to their personal health records.
Are you also not supposed to share like, if they have like a unique disease or something?
Yeah, so psych mental health is something that's like doubly protected with HIPAA. So sometimes if you don't have a reason to be going and looking at their like psych mental health records, so they always have like another layer to protect like psych records. And so you have to go through, and it's called breaking the glass. Like a notification will pop up and be like, hey, you're going and viewing like this more protected information, and then you'll have to click that, yeah, you understand that you need to. So I know it can be very tempting sometimes to be like, oh, I wonder what this person's here for and what's going on. Can I just go and look at anybody's chart because I want to? No. So all that need to know basis type of thing. So I have the limits and conditions for disclosure.
And you can break HIPAA if like they're trying to harm themselves or others?
Yes. So yeah, if they're trying to harm, or if they have like homicidal ideations with a plan and everything against someone else, we can break it, because we need to make sure that that person's safe too, and that they're aware, like, if, someone's gonna come after me.
Have we ever, in any context, been told you could use their phone number to identify them?
ATI said that.
That's what I thought.
Yeah,
yeah.
I'm like, I would never use a phone number. 'Cause-
Okay.
That's what ATI says.
Yeah, I agree with that one. I've always used like for, like patient's name, date of birth, like if they're unresponsive or confused, just cross, make sure to double check their name band, and like I would use the MedRec number then too, just to verify and scanning and all that. So I think we have so many more reliable things to use besides a phone number. So we can, obtain copies of our records, like so much now with, information, technology. We can have everything like on our phone through the apps, like, Unity Point uses my chart, so stuff just pops up there and you're able to see it. So again, of course, thinking about health literacy, not everyone understands that, and sometimes, those results pop up before their providers had a chance to come in and talk to them, or before their providers had a chance to call them if they're at home, so just, making sure that people know that their provider will follow up with them. Yeah, we can sign releases, get copies of our records, we can request our records to be sent over to other places as well. Yeah, we can, request corrections, so like, every time, I check in for an appointment with my nurse practitioner, and, lists, different things, and like, you can ask for things to be removed if that's not what you want on there, or for like diagnoses or things. IT for 300. So what are patient safety indicators?
Would this be like if there's like a fall risk or suicidal?
So, kind of things, so it's federally operated, like the Agency for Healthcare Research and Quality. So intended measures, so preventable complications or adverse events. So kind of thinking about, you can talk about, like fall risk, but then also like preventing pneumonia, UTIs, things like that. So complications and adverse events that can occur after admission to the hospital. So we have a bunch of things that we can do to prevent, for like DVTs, bed sores, things like that. What questions do we have? So what is health literacy and how does it impact equity and patient outcomes?
Like being able to understand what you're reading,
Mhm.
your medical history, your diagnosis. And if like a patient doesn't understand it, or like they think it's something else, it can like get them all worked up if they think it's like more serious than it is.
Mhm.
If they don't understand it, then they're not gonna know what to do like when they go home.
Yeah. So yeah, the ability to read, write, and understand health-related information. So, we talked about how if you're not explaining it to them in a way that they can understand, it's just like, we see that on our end too, when we're up here teaching certain things, sometimes we just see like the look on your guys' faces that are like, okay, I need to probably explain this in a different way then, because you guys are not getting it right now.
Is this like, I think on ATI it says we're supposed to teach at like a 6th grade level?
Yeah.
That's what like this is kind of relating to?
Yeah, and you can even adjust it from there, so I think that like our like overall just literacy level keeps going down, like I wanna say some stuff's like at like 3rd grade level now too. So of course, it has a significant impact on outcomes because, if they're not understanding it, they're not going to do like follow-up care or maybe do what they, someone that's newly diagnosed with heart failure or someone that's newly diagnosed with diabetes. Like for example, so I've had gestational diabetes with both pregnancies. And so with Alice, my diabetic educator, she was amazing, just phenomenal. It was definitely like, she's like, of course you're not gonna like completely cut off like sweets and things like that. It's just, knowing how to count carbs, and was very like helpful and, talk through things, had good visuals of like, had like to show like serving sizes for different things, plates that you could put food on so people could see, like very good visual. And so she knew my background and everything like that. Then second time I'm pregnant, get gestational diabetes again, of course, you know, have an very strong understanding of diabetes, you know, from teaching it, caring for patients that have it, having gestational diabetes. And then I went to this new diabetic educator, and she started, on my first appointment with her, you know, we talked about carbs and carb counting, which of course I was familiar with. And she even went into then, not just counting macros, like my carbs and everything, she was going into specifics of having me count, telling me that I needed to count like micronutrients. So I left there completely frustrated and overwhelmed. Like, I did not like her at all. We did not have a good relationship. I went to my appointments, but I continued to do exactly what my previous diabetic educator had done, because it worked well with Alice. It was working well when I was pregnant with Olivia. I just went to my appointments to do my appointments and say that I was there. So like, I'm someone that has a lot of education. So how do you think someone, like on diabetes, so someone first exposure to diabetes, how would they feel? Like, do you think they would follow up and do what they were supposed to be doing? No. So then that puts mom at jeopardy, puts baby at jeopardy as well. So just thinking about who you're working with, you know, is gonna be tailored to that individualized person there. But yeah, and she was like, wow, your numbers are really good. I'm like, yeah, it's because I'm not doing what you're telling me to do. Like, because she was like, the number of carbs that she had me on was just so low, and then I'm starving. And like, I went to my like week follow-up, and I'm like, I'm hungry all the time. She's like, oh, well, I'm like, yeah, it's because I need more carbs. Like, my blood sugar's fine, I need more carbs. Then also, you know, if we're thinking about like health literacy, like, yeah, we want to, if we have that lower health literacy, we have that increased rate of mortality, so making sure that people understand doing their follow-up cares, trying to decrease like readmission rates, kind of, and that's where I hope that we can have more like of a push for like community health nursing and primary care based. So everything in our system is kind of set up to be more like acute and hospital based. So I think we need more, definitely need more primary. So what is the HIPAA security rule? So we're talking about the privacy rule. What's the HIPAA security rule? There's just a slight difference here. So kind of what we talked about too, like use of cell phones and personal technology. I know that there's been some cases, I don't know if anyone's gotten a letter where like, you know, there's been a breach in a system and that your information might have been, you know, accessed, things like that. So just trying to decrease unauthorized disclosure. So they have, there are a lot of policies and procedures regarding the personal technology devices. A lot of what we talked about, like with social media too, and like I said, just don't really post on anything, and again, don't have any personal information like on your phone type of thing. If it's your own, that's fine. Other thing with HIPAA, are you able to access your own healthcare records when you're at work? Cannot access your own health records when you're at work. Can't access like your family members or anything like that. We did have, when I was at work at Broadlands, I got called because there was a nurse that had a family member that was in the emergency room, and then the nurse was accessing their family member's records, and so they were just calling to see if I saw this nurse like physically in the chart, things like that. So just trying to cover like all their bases before they called her in to talk to her about things. So take that stuff very seriously. So what questions do we have about IT? Quality improvement.
So I know, can you request to say, like, if you're an ICU nurse and you take care of a patient and they're discharged to a lower level, like, floor, can you request to keep updated on that patient, or is that against?
I know like we have received updates from things like if they're like, yeah, willing to have that information shared, yeah. Cause I know like, we've gotten updates on people, like when we've had to transfer people from Broadlawn, since it's level 3, we would get updates. So I think sometimes that's the hard part about working like very like high acuity, like ED, ICU. You either transfer them to another unit, you transfer them to another hospital, things like that, and then you're like, wonder what happened to them, like you just don't know. Sometimes, you know, you can, it's when you start watching obituaries too, you know, that wasn't gonna be a good outcome type of thing. So what is the joint commission?
Listen,
Everyone loves,
I
right?
get that one wrong on every test I take.
You'll get it right this time, right? So what is the joint commission? Yeah, Miss Tiffany. What does the joint commission do?
Don't they like come in and make sure like everyone's following all the rules and
Mhm.
like, I know like when we would be at like Luther and all the nurses would have like their water and snacks like out, but then they're like, oh no, someone's coming, like put your stuff away.
Yeah, making sure that you, like, the halls are free of clutter, making sure that everyone knows, like, where the PMP manuals are, or like how to do certain things. So what do they do? That's what they do. What's the purpose of them then?
It's like, safety.
Kind of safety, so, it accredits healthcare organizations. So it accredits, and so a lot of hospitals, like, it's not a requirement, but a lot of hospitals do get accredited by organizations, can show trust for, like, you know, the consumers of healthcare, that like, okay, this hospital has, you know, gone through this accreditation process. I think my favorite thing about Joint Commission is that they announce when they're coming, so, you know, if they really wanna see how things are, you know, just do those surprise visits. So it can, yeah, do trust, yeah, making sure that things are working. Hospitals a lot of times will be accredited too, because, it helps with reimbursement rates. That's why they'll be accredited. So it's an organization that accredits them, and like what you said, like, you know, making sure that things, are safe, that policies are updated. So, you know, if they ask you like about a policy, you can say like, I would look it up here, like I don't know it off the top of my head, but you know, I'd go here and I would know where to find it type of thing. Yeah, just making sure, you know, safety things. I just remember when I would be at work and Joint Commission would come and I was in triage, I'd be like, I'm just gonna go into my triage office and shut the door, so. So what are HCAHPS and how does the government use HCAHPS scores to promote quality improvement?
Are those like the surveys?
So we're looking, yep, one of the surveys. So it's not gonna be the Press Ganey. So there's a question come in, but we'll kind of talk about the difference here. So 29 items. So I kind of like, yeah. Like how often were you checked on, you know, kind of some, yeah, patient satisfaction here, satisfied with the care that they receive.
Is this the public one or is the press Ganey the public one?
So is that the next question? Let me see. Here we go. What is the difference between
Oh,
Press Ganey?
perfect.
How's it different, or what is Press Ganey and how is it different than HCAHPS? Talk about the HCAHPS. So which one, does everyone get? Press Ganey. Everyone's gonna get Press Ganey. And so then you talked about the public one where you're referring to like the results.
Yeah.
Yeah, so which ones are the results like public?
The HCAHPS.
Yeah, the HCAHPS. So remember, everyone gets the Press Ganey. HCAHPS is a random client sample. Press Ganey is gonna be email. It's gonna just be sent. You're gonna have a survey link, fill it out. Takes just like a couple minutes. And HCAHPS can be a phone call, mail with a follow-up phone call. Yeah, HCAHPS is looking at that client satisfaction. Press Ganey is also looking at client satisfaction, but then it's also looking at healthcare delivery. So, Press Ganey goes to like that floor, to the hospital type of things. They can use Press Ganey to like, look at the care that's being given, patient satisfaction. Where HCAHPS is gonna be public record. I have mixed feelings about like Press Ganey and everything. everything, so like, of course, like, we want to know how we're doing, but results I feel like can be skewed just because it's all their perception of care. And like as an emergency room nurse, like one time we had a client that we were coding right next door to another client, and this client kept putting on their call light and was mad because they weren't getting their Zofran. Let me stop doing chest compressions here, I'm gonna go get that Zofran for you. So just like things like that, you know, like yes, we want to deliver good, safe, quality, effective care, that's our goal, that's why we're here. But of course, being realistic too, and that sometimes someone might just be mad because they don't get their cold plate in the emergency room too, so. Or they're not like getting what they want type of thing, not able to dictate their care, so. Yeah, I mean, like, you know, we're like literally right next door, and like she walked back from the bathroom and saw all of us in there. And it was a GI bleed, and it was messy, there's blood everywhere, and I'm like. What is the difference between Medicaid and Medicare? So Medicare, who can be on Medicare? 65 and up, and then there's some other special populations that can be on it, do you remember? Disabled, end-stage kidney disease, and then what about Medicaid?
For like your lower income.
Lower income.
Kimberly, I'll always remember that from what you said.
I
in
always
class.
I
I
always
realized
get it
before people
wrong.
get AIDS. You said that.
Wait,
what did she
I'm
say?
sorry.
No, that's how I remember it. Because I always get the two mixed
So
up, and
do I.
she was like, poor people get AIDS, that's what she said. And it just like they,
Not necessarily
like-
true.
yeah, but like that's how I remember it.
Yeah.
I remember it as in like Medicare, like we seem to care more about our older adults than we do about, yeah,
See, another good one.
yeah. We
And
care
okay.
more about our older adults, I guess, so then we provide aid to, yeah, the lower income. Yeah,
That's how I remember it.
so Medicaid,
You're amazing,
is
Kimberly.
funded and administered by state and federal, so it's both. So yeah, your eligibility is gonna vary from state to state. So yeah, you said Medicare, older than 65, people with disabilities, and then, anyone with end-stage renal disease. Kind of think too, like Medicare, like not always, but a lot of times they're gonna require some higher level care, just cause they're older, disabled, have end-stage renal disease.
Why is it just end-stage renal disease? Like, why not anything else that's?
Yeah, and stage heart failure.
Yeah. I think, just because of like dialysis and all the care that goes in, and you know, if someone's having to be on dialysis, it's more difficult for them to work, like, you know, a lot of times they might have to go in like 3 times a week, and so just to give some more assistance. Okay. So what's the purpose of an incident report? Gone over this so many times, from the beginning of the semester to now.
Just documenting what happened,
Mhm.
so like the factual like record of it is kept.
And then what can we do with that?
You can like learn from it and prevent it from happening again.
So kind of we're thinking about it for quality improvement purposes, analyzing those trends, and create a plan for change if needed. Was it just like a one-off error that it was like, I was busy, I was distracted, I was tired, and I made a mistake? Or was it like, this has happened consistently with a variety of nurses, like we need to change something?
Can we use these in court?
Incident reports,
Like if I were to like fall, could you like then use the incident report to be like, well, actually she wasn't doing this, this, or this?
I think it would probably like pull in, like it doesn't get filed, I'd have to look, they'd have to contact the hospital to get that, since it wouldn't be in the patient's chart. So I mean, you go in and you fill it out and everything, but it doesn't actually get filed in the patient's chart. Type of thing, so like, yeah, if you have like the patient that falls type of thing, you'd probably see, you know, have like documentation of the, you know, someone falls, because we're gonna do like some evaluation on them, probably some x-rays depending on, you know, scans. But the actual incident report isn't like filed in the chart. It's it's not like documented in the chart. So like, say I make, and say client falls while I'm caring for them, I fill out the incident report, Kimberly comes to work, she takes over on that client, she can't look through that patient's chart and see the incident report, that I completed for the patient.
So is it possible we, as a person, a patient, could be given a wrong medicine and never know it?
Should be speaking, you should tell them, communicate with them, like what happened, and just so that you can ask them to report any, like, you know, say you, accidentally gave like a beta blocker to them. You know, you want to have them watch for, you know, symptoms of like hypotension and bradycardia and things like that, so you should communicate with them as to what happened, so. I'm not saying that that does happen, but like, should, just kind of for that honesty and transparency in the care.
There's this form that they have at the VA that's like, you can fill it out if you feel like your assignment is unsafe.
Mm-hmm.
Like, is that everywhere? But, it's, my, nurse manager used that to get safe staffing on the floor. She said, if I give you an assignment and you feel like this is too much and it's gonna affect your client's safety, I won't take it personally, fill it out so I can turn it in.
That's
And that
awesome.
floor is so staffed, like the
Mhm.
the nurses have like 2 or 3 patients, it's awesome.
And I always hear really good things about people that are on 3B, or like,
Yeah, I love that floor.
yeah, that's good,
Mhm.
that helps a lot.
Mhm.
And no, that's not everywhere, so I think that's awesome that your nurse manager has that and is working to get that, so.
She's only been there 2 years, and they say it's been such a difference since she's been there.
Yeah,
So,
yeah, if you're the nurse manager, it just makes such a difference for the culture of the floor that you're working on. So yeah, when you're interviewing at places, you don't ask about the culture and things like that, so. Alright, so some review to get us thinking about that final that's coming up. So what's the difference between the scope of practice and the code of ethics, and where can you find these? So what's our scope of practice?
Just like what we can and can't do.
What we can and cannot do, and where can I find my scope of practice, or the LPN scope of practice? Yep, Nurse Practice Act, and so if I wanna get on and figure out what the scope of practice is in Iowa, what website will I Google? What organization will I go to? No, not the American Nurses Association. Iowa Board of Nursing. Remember, your Board of Nursing is who oversees your scope of practice. So it's a state organization, scope of practice is gonna vary from state to state. What's our code of ethics? And where can I find these? So does code of ethics apply to universally all nurses in the United States? My scope of practice might vary depending on where I'm practicing. What about the code of ethics? Is that gonna be universal throughout the United States? It's gonna be universal. So what is the code of ethics? Just broad definition, you don't have to go through all.
Just doing the right thing
Mhm.
and like not doing something that you think is like gonna hurt the patient.
Mhm.
And if you like see someone, I think that was a test question, if you like see someone on the street, it's like ethically right to do something, but you don't
Like
have
for
to.
the, Good Samaritan law, yeah, like, we're not legally required to do something for the Good Samaritan law, but probably ethically, we will do something, just because probably why a lot of us went into nursing. And then remembering that with the Good Samaritan law, you will be protected as long as you practice within your scope of practice. But, so the ANA is the code of ethics, so you knew that it was one of them, right? So scope of practice is gonna be our Nurse Practice Act, the Board of Nursing, and then the code of ethics is gonna be the ANA. Which client would you see first? So some prioritization. Client who had abdominal surgery 3 days ago and is feeling constipated. Client who had hip replacement reports a pain of 4 out of 10. Client who has an indwelling urinary catheter removed 8 hours ago and reports inability to void, or the client who is scheduled for discharge today and states that they're ready to sign their paperwork.
See,
C, why C?
cause their bladder couldn't go pressure.
Bladder, yeah. Yep.
Or is it hours ago?
Yeah, 8 hours, it's been a long time since I've urinated, so yeah, I would expect there to be a little bit of a delay, but not 8 hours. Figure out what's going on there. So which represents an authoritarian approach to manage an increased rate of med errors, inform the staff of the penalties that can result from medication errors, encourage the staff to have 2 nurses verify medication orders, provide a suggestion box for the staff to submit ideas, or ask 3 experienced nurses to help investigate common causes of the errors. So authoritarian, A and why A?
I feel like
Seems more mean.
they're showing their authority.
Yeah. Like, kinda like, I'm in charge, I'm the boss. So how would you respond to that, if that's what your nurse manager said?
Probably
Cry. Would you report errors? No. Like, if I'm gonna have penalties, are there supposed to be penalties for errors? No. Cause then you won't report them. Which client should we see first? Scheduled for a tubal in 2 hours and is crying. Client who has a peripheral vascular disease and has an absent pulse in the right foot. Client who has type 1 diabetes and needs a first dressing change of an ulcer. Or a client who has MRSA and has an axillary temperature of 38. B? Why B? It's correct.
Because there's just no pulse.
No circulation, ABCs.
Circulation.
Yep, no circulation, so that's who I would see first. Last one here. Which task can be assigned to an LPN team member? Determine the swallowing ability of a client who had a stroke, who's gonna do that? Speech, yeah. Provide an enteral feeding to a client who has Crohn's disease. Can they do that?
Yes.
Develop a teaching plan for a client who has a new diagnosis of type 2 diabetes. Nope, who's gonna be doing that? The nurse. Weigh a client who is 3 days post-operative following a coronary artery bypass grafting or cabbage. So with these tasks, which one would we give to the LPN? Can they do D?
They can't do that, you do that, give that to the
Give that to
PCT.
him.
Give that to the PCT.
So you would do B.
B, so they can do the feeding to a client who has Crohn's disease. So again, just remembering what our scope of practice is for like our LPNs, our techs, so, yeah. Remembering that like we can do all of these.
So when it says which one can be assigned to an LPN team member, it is true that they can weigh somebody.
Yes.
But that's not the most right, cause you're looking for something that like the highest level of ability that they can
Do
do.
within their scope of practice, yeah.
So you need
Yep.
to assume that there's also a UAP there.
Yeah, if there's a PCT task and an LPN like task, you would select the one that is like solely LPN.
Okay.
Cause it'd be like the same, you know, like for like if it were to be like an RN and it was like PCT things and one RN thing, like assessing and then other things of like monitoring, like obtaining like weight, intake, output, feeding.
I have a question
Questions?
about leadership, even though it's not for this.
Mm-hmm.
Does leadership, is it like it has to be earned? Cause like there's a question on the test that was like leadership must be earned, but I took that as like an always
Oh,
question.
and like an all one.
Yeah.
Yeah. So, yeah, leadership is something that will be earned, just because,
So it must be earned.
it's not something that's assigned, I guess, is like the difference between the two, so. Yeah, that you're sharing like your perspective on the wording of that it seems
Well, cause I
it's
took
an
it as like,
all.
whenever it's a question that says always, like that's never
Yeah,
right,
the all,
so that's how
always,
I took
never,
that question.
like those type of test taking strategies, yeah. So it's gonna be earned, like just through, cause like, you know, you go in and you start work right away, like, are you necessarily gonna be a leader like right away in your first little bit of time at work? I mean, management might try to make you a leader and like by being charged nurse shortly after orientation type things and, but yeah, so management, remember those are the assigned roles where the leadership is what's earned. So you can be a manager, but not necessarily be a leader, but you can be a leader without being a manager type thing. Does that kind of help clarify some of that? Yeah, Joanne?
Did we do 500 for quality improvement? Did we?
So the purpose of an incident report, we talked about, we're gonna report those, errors, analyze trends, and plan for change. We talked about how the incident report's not gonna actually be like filed in their chart type thing. What other questions? ready for the exam. I hope that